everyone. Welcome to Preemie Chats. Preemie Chats is a program that is for healthcare professionals and parents to come together and talk about what matters most to us, to explore new ideas, and to learn together. So thank you for joining us. I'm Leah Whitehead. I'm the mom of a preemie, and I'm also a former journalist, and I'm happy to be your host today from Halifax, Nova Scotia. Preemie Chats was created and is put on by the Canadian Premature Babies Foundation, also very well known as CPBF. The foundation is a parent-led charitable organization that helps families in and after NICU through education, support, and advocacy. If you have a heart for preemies, whether you're a healthcare professional or a family, I'd invite you to head over to their website. It's there on the screen, canadianpreemies.org, and there you will find resources, the latest projects, and most importantly, a community of people who want to see our little babies thrive. Today's session is live, so please bring your voice to the table. I'd love to hear where you're watching from. You can leave in the comments your name, where you're watching from, and also any comments, personal experiences, or questions you might have during the program, and we'll try to get to them today. It is through rich conversations like the one we're going to have today where we advance practice together and learn. So please participate and let us know where you're watching from. Babies who are born prematurely are at a higher risk for adverse health and developmental outcomes. High-risk infant follow-up programs help observe babies' development and milestones and aims to support them and their families during early childhood. While this is instrumental in helping families, standards of care, the structure, content, and the timing of clinical follow-up varies considerably. So today we're going to hear about the varied approaches, identify gaps, and discuss efforts to develop more inclusive priority setting to achieve optimal outcomes for all infants and their families. And to lead us in this discussion, we're going to be joined by Dr. Jonathan Litt. He's a practicing neonatologist and health services researcher at Beth Israel Deaconess Medical Center. He's the director of the NICU Growth and Development Support Program at Boston Children's Hospital and Assistant Professor of Pediatrics at Harvard Medical School and Social Behavioral Sciences at the Harvard T.H. Chan School of Public Health. Dr. Litt has been passionate about follow-up for a long time. His fellowship and dissertation work centered on the impact of early intervention programs for low birth weight infants on functional outcomes at school age. His body of research is focused on the long-term health and neurodevelopmental outcomes of high-risk infants, the role of care integration and population health management in novel models of high-risk infant follow-up, and the equitable access to and effectiveness of community-based intervention services for children with medical and developmental complexities. Thank you so much for joining us here today, Jonathan.
Oh, it's such a pleasure to be here. Thank you so much for having me.
I'm going to put your presentation up for you, and I'll let you get right to it.
Fantastic. Thanks so much, Leah. This is such an honor to be invited here to speak with you and really engage in conversation around this topic that I am so unbelievably committed to and passionate about. And that's for the follow-up and follow-through care that we provide for infants and families after they leave the NICU after a preterm birth. I have nothing to disclose. So here's a bit of a roadmap for the comments, the remarks I'll make for the first part of this session and time we have together. The first is to think about what are the care needs after NICU discharge? So what are those needs and are they being met? And if so, or if not, for whom and why? The second part will be to discuss how might we address some of the gaps that we know exist in follow-up care. And we'll talk a bit about a few of those different models. Certainly won't get into detail. I really want to spend some time talking with you about your experiences with follow-up and how we might address the gaps. But the last piece is to really think about, how do we as a community set priorities and then standards to hold ourselves up to a standard for high quality, equitable care after NICU discharge. So for the first piece, addressing the NICU, the needs after NICU discharge. So I will say, sort of as was already discussed, I am a practicing neonatologist in the United States, south of the border. And here in the US, the American Academy of Pediatrics actually put out a statement about the importance of follow-up after NICU discharge. But it's a bit vague, I would say, and a bit agnostic around some of the details. And it emphasizes the importance of arranging follow-up, sort of for those of us in the NICU care community, but it's not specific about the location, about where that care needs to occur. And I have this quote from the position statement that came out, talks about the primary care physician being sort of the first line of follow-up care, but then with the understanding that there may be more specific needs, that one might have to include other members of the care team to provide follow-up care. There's a wonderful statement from the Canadian Pediatric Society as well that I will say is a bit more specific about where that follow-up care takes place, perhaps what the content is, and who's providing that care. And really getting to the heart that follow-up care, just like NICU care, is a multidisciplinary, interdisciplinary endeavor. What is follow-up care? What is sort of the lay of the land? What do we know about it? Well, we know that can either take a rather narrow clinical or a research focus. It typically involves a prescribed set of assessments, particularly for neurodevelopment over time. It's time limited. Quite often, it's limited to the first 2 or 3 years of life, sometimes up until school age. And for very few programs, very special programs, the follow-up timeline is extended through school age. It's often conducted by a very small group of professionals, which I will say is often disconnected from the NICU itself, which really interrupts any sense of continuity, I would imagine, from the perspective of the family. It's also distinct from NICU operations in the sense of often, if they happen in different locations, there might not be the free flow of information from one to the other. Who is deemed quote unquote high risk? And we can talk about what that really means and should we even be using that terminology. But what do we mean by high risk and who's being followed? Well, usually it's specifically designed a defined group of infants by gestational age and birth weight ranges, by medical diagnoses, or sometimes social risk or other demographic characteristics. The current focus is rather narrow, and unfortunately, in my view, really misses opportunities to follow through for families after NICU discharge. Follow-up occurs in a variety of settings, based in sometimes academic medical centers. They can be research-based. Some complex care clinics provide follow-up care. There are sometimes subspecialty clinics like neurology or pulmonology that provide follow-up care. And in some cases, there are some primary care clinics that provide specialized follow-up for their preterm infants. The services that are offered are also varied and variable. They can be medical, developmental, psychosocial for the infant and for the family, and some offer care coordination services, but not all. We also know that there are multiple stakeholders. Families, of course, also primary care providers, subspecialists are part of the care team, early intervention programs, educators are just a few of the stakeholders that are really invested in follow-up care. Because of all of this variability, we know that follow-up care can be complex, it can be fragmented, and quite variable. The current approach, unfortunately, because of that variability, systematically leaves behind several different groups of infants. We know that moderately or late pretermly born infants are not always included in traditional follow-up programs. Term infants with significant NICU admissions and significant health problems at the start of life are often not included. Infants with surgical conditions who may have specialized needs often don't receive the follow-up care that they are due. And infants with uncommon genetic diagnoses, those who we're finding more and more these days as we've had this explosion in genetic testing in the NICU and for newborns, we're detecting conditions and variants that might have an impact on development, and yet we're not following those families either. Many families are left behind. There's a lot of work that's been done showing that racially minoritized infants and families are often left behind. Black families in particular, compared to white, are followed about half the time. Language is also another predictor of whether or not we're receiving follow-up care, with those who speak English primarily here in the US. English primarily speaking families receive follow-up care at much higher rates than their peers who are not primarily English speaking. And we also know that we're leaving behind many communities. So very low opportunity, and those are economically and educationally opportunity measures. Very low opportunity neighborhoods also are lacking follow-up compared to their higher opportunity cohorts. This is a figure from a paper that we published 2 years ago now, showing the high degree first of variability in terms of follow-up of families, infants who are born extremely low birth weight in the Vermont-Oxford network. So this is about 60 centers who contribute data. And you see that follow-up rates range from 0% to almost 100%, right? With a lot of variability in between. But we also see here that there's variation within each hospital by race and ethnicity, meaning that even within the same institution, who you are, what you look like, who your family is, might determine your likelihood of receiving follow-up care after going home. Well, what does this mean sort of practically speaking about the care? Not only does it really signal that we are not following through on the duties that I would say that we have to follow through all families after they go home, but there are some practical things about what that means in terms of health service delivery. We know that many infants after going home from the hospital have delayed or missing routine vaccinations. Many lack a medical home and miss subspecialty services as a result. There are frequent rehospitalizations and missed neurosensory screening, particularly vision and hearing screening that are recommended after preterm birth. There are barriers to early intervention service receipt that follow-up programs help iron out. And interestingly, as we are learning more and more about our preterm population as they grow and age into adolescence and adulthood, we're actually recognizing that there are unmet adult physical health problems that are going by the wayside. All of these things could be addressed by robust, universal, high-quality follow-up care. So with that as a backdrop about what are the needs and what are some of the gaps, how do we address them? How have we addressed them as a community? The first is the family-centered medical home. This is likely familiar to many of you who are with us today, who are take their children to a primary care pediatrician. The gold standard of sort of pediatric practice for many decades now has been the family-centered medical home. There are 5 different components to that model of care for well child care. And that's, do you have a personal doctor or nurse? Do you have a usual source of sick or well care? Is there access to needed referrals? Do you have access to effective care coordination services? And does the practice meet certain definitions of family-centeredness? And by that, they mean, Is there shared decision-making? Is there cultural competence, or what we now would call cultural humility? And is there satisfaction with inter-team member communication? In general, receiving family-centered medical home or having care in a family-centered medical home is associated with improved access to services, greater family satisfaction with care, and lower healthcare costs. We've also shown that care coordination services that are received within the context of a medical home is associated with lower odds of having a functional disability for children with complex needs. So there's some real benefits to having your care within a medical home. I apologize for some of the extraneous text on the slides. Unfortunately, we've shown both in a local cohort of infants and in national cohorts that preterm infants are less likely to receive care within a family-centered medical home, at least here in the United States, than their term-born peers. Having a family-centered medical home is actually associated with fewer unmet healthcare needs. And unfortunately, there's significant racial and social inequities in who is having access to a family-centered medical home. This was shown in both, as I said, a local cohort of children in a national survey of children's health in 2011 and 2012. And then in 2019 and 2020, we saw these differences persisted. It turns out that only about half of American children in the preschool years receive care in a medical home, and even fewer children who have a special health care need, which I have to say is a bit alarming, recognizing that this is the gold standard of care for pediatric care, at least here in the United States. Only half of children are receiving it, and those who probably benefit the most have the least likelihood of having access to that. Another approach for addressing some of the gaps in post-NICU care for our preterm infants particularly are transition home programs. And I can't think of a better example or a better model than the model that Betty Vore and her colleagues at Brown University in Providence, Rhode Island have put together and studied and shown the effectiveness of. Their Transition Home Plus program is really a gold standard for those of us in the field. And it really recognizes the importance of, one, starting before NICU discharge in thinking about that transition home with meeting families, rounding with the team and rounding with families, explaining what the role of high-risk infant follow-up is, what are some of the things that we are looking for to help support growth and development along the way, and addressing any needs that families might have as they anticipate discharge and transition to the community. The other piece that I have to say is quite innovative is that there is a real dedication to following through on what is committed to during those conversations in the NICU. And by that, I mean, there's a phone call to families within the first 2 days of discharge. There is somebody who is a part of the follow-up team who carries a pager 24/7 for the first several months of that child's life out in the community to answer questions that come up. And there's a home visit that the team does, in addition to the regular cadence of clinical follow-up visits. So it shows a real commitment and dedication to providing high-quality follow-up care. A wonderful example, again, of really high-quality follow-up and follow-through is by our own wonderful, my friend and now colleague, Paige Church, and colleagues. I'm sure many of you know who are on this session today. And the touch points approach to follow-up care really is something that I think is so wonderful, and I think a real model that we can all hopefully strive to employ. It's a broadening of the focus of follow-up care by really turning away from this sort of strict and what I would consider arbitrary visit cadence, right? Of sort of that's been, I think, I certainly feel like I've inherited from the era of follow-up that really came from research, right? And the cadence of research visits for follow-up. And to think about how can we be more responsive to the development of the child over time, recognizing that the needs change as the child grows. So the touch points really are sort of the when, right? Sort of the where are the times in that child's early life when families could most benefit from some guidance, anticipatory guidance, early intervention. There's an objective, so there's a what, right? What does each visit actually entail? What are we looking for? What do we aim to achieve? There's a how, right? There's an assessment that goes along with it that I think is really wonderful and wonderfully instructive for those performing follow-up. And then there's a who, right? There's a who are the team members who are most important to be involved at each of those different touch points. It's a wonderful way of laying out a course of follow-up through childhood that really is responsive to the developmental needs of that child and family. And then, of course, it emphasizes the wonderful F words, right? Rather than thinking about disability and thinking about risk, it really turns into what are the goals of the family for their child? Thinking about fitness and function and friends, family, fun, and the future, right? And planning to really optimize thriving for infants over time. This is a bit of a busy slide, but I wanted to share some of my work has been on thinking about care integration from sort of a health services perspective. So integrated care is defined as the seamless provision of health services from the perspective of the patient and their family across an entire care continuum. It's essential to achieving the best health outcomes for every patient. And there are several core activities that are involved with care integration. And those are high quality handoffs, care mapping, having action plans, something that's actionable for the family, and of course, measurement. Because if we can't really measure what we're doing, we won't know how well we're doing if we're missing things, duplicating things, or not having any general sense of effectiveness. You see here on the lower left, this is a map, an exercise that a family was asked to perform to map all of the different aspects of the child. This is a child who had significant medical and developmental needs. All of the aspects of their care to help support their growth, development, education, and the like. The thing that I think is most striking to me and why I like to use this in talks I give, both sort of lectures and then also teaching trainees, is that if you'll notice the medical, and you can't see this, I know it's a little hard to read, but the medical system is only in that darker blue in the left lower quadrant there of that figure. Recognizing that, okay, there are a lot of medical things that are going on with this particular child and their family, but then think of all the other sectors, right? The other sectors represented in different colors are the education sector, the home care sector, the social service sector, right? All of these different pieces and players, and recognizing that healthcare is just one small, of course important, but small part of what's happening after the child and family transition to the community. And recognizing that there is so much work that we can do to be helpful to help integrate all of those different players and pieces of the care team. We've embarked on a bit of a demonstration project here at Boston Children's Hospital, where our follow-up program is based, to really put some of these principles into practice for our preterm infants after they go home from the NICU. We were lucky it was supported by our Medicaid, our public insurance program here in the state. And it actually brought together 3 different programs that provide care for preterm infants. So our NICU grads program in neonatology, our bronchopulmonary dysplasia program in pulmonology, the Center for Healthy Infant Lung Development, and our growth and nutrition program in GI. And I'll describe just very briefly the 4 different parts of this program that we've been implementing and studying. So the first is having a clinic-based population health manager. So population health is thinking about shifting the focus away from just the one individual to a whole population of patients and their needs. And what we've done in terms of putting that into practice, we have hired a clinic-based population manager for each of these different programs. And Their roles are really to build a care relationship and navigate subspecialty and primary care and community resources with the family, to provide leadership across the multidisciplinary team, to track progress and or challenges along the care plan with families, and to really empower families in the care of their child as they grow and develop. The second piece is proactive patient care tracking, and this is a bit of it in its infancy right now, but we have attempted to identify the children in our programs, each of our individual programs, who have the greatest needs, for which we will be in sort of a wonky term, the locus of integration, or the anchor. What that really means is we communicate with the family and say, we are the integrator for your child's care. We should be your first go-to. Here's and the other tracks are, okay, sometimes then if we're not that locus of integration, we step back and we're the co-managers, and that's fine. And it's really important, again, because we know that when these roles are not well defined, care can either be missed or it can be duplicated, both of which are markers of inefficient, low-value care. The third piece is interprofessional education and collaboration, which we do monthly and quarterly in different ways to really keep ourselves honest and apprised of what's going on. And then the last one is care planning and communication. And there's several different tools that I'd be happy to share and talk about. We wanted to get a sense of how we were doing. And so we actually did a bit of a pilot survey with a validated tool called the Pediatric Integrated Care Survey that we've adapted for our preterm population, to really have a sense of, from the families, what are your needs, how are we doing, and what can we do better? There's some things that I think we were doing well. So 80% of the respondents said that the team thought that the team listened carefully to their needs. And 80% thought that really felt that the team discussed big picture goals for their care at each visit. Okay, I think that was really great. Perhaps sort of where we have a little bit of room to improve is that 55% of individuals were aware of the advice that the other members of the care team had given, which sort of means that, okay, well, maybe there are some gaps in the communication. 59% felt that we as a follow-up program were addressing family impact of health decisions along the way. I also think that there's some room for improvement there. Where there's some really significant room for improvement is in making a written care plan, which is a goal that we all should have, right? That at each follow-up visit, families should really have a sense of what are the goals, who's responsible for making sure that they're actually completed, and what happens, what are the contingencies if they don't actually happen, right? We're not doing a good enough job. And 39% of respondents felt that we addressed additional family stressors, so that we weren't really taking into account anything beyond what was happening sort of with that medical piece of that child's life, which again goes to show us that we're not quite doing the job that I least aspire to do. So in the last few minutes before I really am excited to open up the discussion, what can we do? How can we do better? How can we move forward? So priority setting is super important. And I know that there are several groups that have done some really foundational work. Those of you in Canada have really done some wonderful work with the Parent Voices Project, which I've learned so much about and so much from, I have to say, in reading and talking with some of the authors. But recognizing that, some of the things that we do during our follow-up visits aren't really all that important to families. And we have an opportunity, and I'd say missed opportunity, to really meet families where they are, to provide them what they really need and what they most value. In some of the quality improvement work I do on the provision of high-risk infant follow-up here in the States, we talk a lot about our low follow-up rates, and we're really only, on average, following half of eligible children in our programs. Well, I think this work is really instrumental in showing us, well, parents may not come, families may be quote unquote lost to follow-up because we're not offering something that's of value. And I think that that's a really important piece to consider. A group from the UK and Australia have they're just in the process of analyzing data from a priority setting project of their own. This is a priority setting to really rank the top 10 unanswered questions about the most premature infants that are on the minds of all stakeholders, parents, providers together, and community members, actually. It sort of was very broad. It cast a very broad net in terms of who they wanted to hear from. But this is really, rather than a priority setting for clinical care, it's really for a bit for research, for sort of funding priorities for unanswered questions. And it's a wonderful group, and I think they are going to find some really important information about what the community really wants and needs for this population of infants. But it's not specifically focused on follow-up per se. There are some examples of standard setting, though, from some other countries. So Canada, as you know, has a position statement on preterm infant follow-up in Canada, and sort of sets out very nicely some ideas about what follow-up should look like and for whom. In the UK, there's the National Institute for Health and Care Excellence has put out a guideline particularly for the developmental follow-up of preterm infants in the UK. Right now in Australia, the Centre for Research Excellence in Newborn Medicine has also put together a practice guideline that they are in the process of sort of vetting and working with the state to help sort of finalize and put into practice. And I'm involved with a group here in the States with the American Academy of Pediatrics, a working group putting together a technical support report on the provision of clinical follow-up care here that's in progress, with the hope of then developing some standards by which we can actually guide best practices in follow-up. But what I'll say is that all of these are very well-meaning. There are a lot of really terrific energy and intellect and insight and experience that are being brought to bear for these standards setting projects. But there's, in my view, a lot that we still have to learn before we actually can get to the step, at least here in the United States, of setting those standards, because we don't really have a really good sense of what are the priorities of all the different stakeholders. And so in terms of addressing the gaps, and this is a figure from a recent paper of ours that's really aiming to apply the precepts of life course health development, thinking about how we can shift from a very regimented series of follow-up experiences that are very much based on what we as clinicians and researchers think are important, to really turning it into a health service that's first and foremost there to help support infants and families and to meet the needs that have really not been addressed. We also recognize, at least here in the States, that we can put together guidelines and sort of standards all we want to, but if we haven't really done that background work, we'll have only gotten halfway. And we don't really have yet a mechanism for really sort of tracking, enforcing, encouraging people to use them, right? And it takes a lot to change people's practices and to change people's ideas about what we should and shouldn't be doing. So to end, I'll just say that a group of us came together at the big pediatric academic meeting last year from the organizations that you see here to talk about exactly this issue around how do we set priorities for clinical follow-up moving forward? How do we engage meaningfully with the stakeholders? I mean, families first and foremost, who have been left out of the conversation about what follow-up care really is and shouldn't be, but also all of those other stakeholders in the community that I mentioned. so that we can then work on translating the priorities into some sort of standards by which we can actually measure and follow progress for high-risk infant follow-up, akin to what we've done for the NICUs, right? I mean, it's really interesting to me that in the ICU world, in the hospital-based world, we set standards, we follow data, we benchmark our outcomes against others, our peer institutions, and what's happening nationally, so that we know where we are and how we can make improvements and learn from each other. And I think that it's time that we do that for high-risk infant follow-up as well, so that we can actually go from follow-up, right, which is kind of what we're all doing, to really following through on the commitments we make in the NICU to families to help their children grow, develop, and thrive. So with that, I will stop and hopefully have a good conversation.
Thank you so much for your presentation. We've had a lot of engagement. And great. Yes, I'm going to start by reading something that was on the event itself. It wasn't a comment on the presentation, but it was on the topic. It's Ashley Polson. So she said, I was born at 24 weeks and was recently diagnosed at 40 as being on the autism spectrum. I was followed through a NICU follow-up program and was part of at least one study in general of former preemies from 1983 until about 2001. I have read preemies have a higher risk of being on the spectrum compared to full-term babies. Unfortunately, it wasn't known about then like it is now, as being on a spectrum instead of more stereotypical presentations. And in most cases, there is not an affordable option for adults to be assessed like there is for children. There are still so many gaps for adults, including those who were born premature.
Wow. Well, I first want to thank you. Yeah. Oh, go ahead. Sorry.
Go ahead. No, go ahead.
No, I just wanted to thank you for reading that and for the comment. I think that's there are a lot of things there that I feel like I could react to, and I think first and foremost, I'll say we certainly absolutely want to include people who are born preterm themselves, right? That's also a community of stakeholders that I didn't mean to leave out, and thank you for reminding me of that. But the issue, the question around autism and autism spectrum is really quite interesting to me. It is something that we're learning a lot more about right now in the field, and I would say it isn't something that classically had been so much on the radar. Certainly 30 or 40 years ago, in terms of what we had known about prematurity. I will say that it's very interesting. We were just talking in clinic this week. We certainly are making the diagnosis far more often than we used to, even in the 10 years or more that I've been practicing. But it's different than the classical autism that we sort of know about from reading and from the community, or anybody that people we know ourselves, or just it's a little less, I would say, textbook. And I think that also can be a challenge for providers in terms of recognizing and diagnosing. And my concern, and the concern that we shared with the psychologist we were talking with, is that can get in the way of early identification and early intervention, and helping families and children earliest, when we often we feel like that's the best time to intervene.
We have another comment from Sarah Carter. She said, similar to what Ashley said, I am also an adult who was born premature, and I find that most doctors and specialists do not acknowledge it. They just think that was then, you're fine now. Being born premature has no bearing as an adult, as far as most are concerned.
Wow. That's also, well, thank you for that comment. And I think that that also resonates quite a bit. I think we are doing a bit, I'll say, in two different areas, thinking one about prematurity education for general pediatricians in the community and recognizing that as children grow, even in pediatric practices, there's a blind spot there. But I had not thought about even in the adult world, right? I mean, that's a whole other piece. I shouldn't have a blinder. But the other piece that I'll say that there are some really there's some great work being done in the UK. My colleague Samantha Johnson, who's a psychologist, who's really interested in translating what we have learned about learning and prematurity and behavior for educators, and that schools, that teachers also, just like what you're describing about sort of adult doctors and caregivers, but that educators also really need to know. And they've developed a really wonderful curriculum to say, yeah, like here are some things you should just be aware of, and that kids may need some extra support, and that's fine, but you need to be aware. So that, but I had not thought about the adult sort of medical community. So thank you.
We did have, just to go along with your comment about people not necessarily using it if it's not valuable for them, is we did have a comment from someone, Corey, who said that they attended the World Prematurity Day party that CPBF puts on. But she said that her first baby was born at 29 weeks in 2013, and her weight was 2 pounds 1 ounce. She's now 11 and is a healthy, beautiful, and smart girl. But she said they stopped going to their follow-up because they got busy with their second baby, who was full term. So she's always interested in learning more about it. So it's interesting. Again, we're looking at families who life carries on after NICU. Yes. And so what, so what do you think about that comment?
Yeah, no, I think that's an important comment, and thank you. I think again, it to me, it comes back to value, but also meeting families where they are and where they can be. Yeah. And part of the other work I do, which I didn't really talk about, is thinking, so much of follow-up happens at academic medical centers that are almost all very urban, and not always easy to get to. And so are there aspects of what we do that can be administered in different ways, can be consumed, for lack of a better word, but by parents at times when they can do it, not again, during a clinic visit, right? Like my clinic is only on Mondays from 8 until 4. So if you can't come to my clinic, right? I mean, that's not really very fair. So, and I think there are a lot of things I think about in terms of rurality and connectivity and and transportation and all of that. But I think this raises another piece of it. It's just life, right? You have other children, you have whatever it is in your life, right, that requires time and attention. But are there pieces of at least the educational piece that we provide, anticipatory guidance, that can be consumed when you're home during your downtime that might not be during the hours of a clinic visit?
Right.
We are thinking a lot about that.
I'm wondering about as a parent of a preemie myself, and something that I'm very passionate about is an aspect of development that I find is often ignored, and that is our social and emotional development. And so how do you look at that? And is there more to do in that area when we do follow up with our little ones?
There's quite a bit. And I think that is an area that is, for lack of a better word, sort of burgeoning. I think there are folks in follow-up who have always recognized, and I certainly am learning a ton from my new colleague, Paige Church, who has that developmental background as well, who it's very clear, but also from the psychologists that I work with. And I have to say that I'm really lucky that in the program that I'm in, we have psychologists who work with us who are able to sort of key in to those aspects of development in a way that many of us medically trained people aren't. So that's the first piece, and not to say that, oh, everybody needs a psychologist in order to do it, but it's raised my awareness. And so I think there are absolutely things that we can and should be doing at some of those touch points. So again, sort of the early visits are very focused on feeding and motor, right, skills, and how is that going,
Right.
and then language development. But then at a certain time, right, these social and emotional skills come online, and we need to do a better job as a community of training, right, about what to look for, how to assess it, and then, quite frankly, how to talk to families about it. I think there's, maybe because of some discomfort, maybe because of some lack of feeling like there's lack of training or understanding around it, there can be some unease, I think. And I have noticed from families, there's some variability as well. Some families come in and they say very explicitly, I'm worried my child might be on the spectrum. And that's very helpful. That sets the right. So, okay, this is what this is going to be about. There are other families for whom they might be thinking it, but are just scared to ask. And so we need to do a better job, I think, as follow-up providers to be able to meet those families. It's very easy when a family comes and says, I have concerns. You're like, great, tell me those concerns. I've got it. But families who don't, I think those are the families that we really can do a better job of serving. And then the point that I think the first commenter made about sort of getting access to diagnostic services, right, or sort of, if you haven't concerns that sort of meet the threshold of, okay, we really do need to have a testing, a diagnostic sort of evaluation. If you ask those questions and you find those answers, we need to make sure that we have some place to refer families. And that's a whole other kind of question. But the resource piece is also, and it's hard, and it doesn't mean that we shouldn't try, but I think there's also some, might be some trepidation around that as well.
I know for us, I really valued about our follow-up program is they would give us activities that I could do with Tessa that would kind of challenge her, which I always loved to just, see how much she could do. And I wonder if that's a similar, like it was always on the gross motor, the fine motor, those very tangible skills. But whether there's even room for those social and emotional kind of activities, and say there's room here for that too. And that as baby's developing or as your child's developing, that is very much a part of who they're going to be. And so also providing those kind of activities.
That's true. That's absolutely right. And I have seen some of my colleagues model those kinds of things, sort of which I think is really, really great. I think, again, it to me, it just comes down to we're not as attuned and we're not as familiar, I think, as providers around some of those kinds of skills. How do you teach some of those skills? It is not new, but sort of newish to me, and I think new to the neonatology community, at least here in Boston. So this idea of early relational health, which is how parents and children engage and how they're, so the quality of their interactions. And I think there is something to be said about, okay, you observe how that's going, and then the next piece, I don't think we're quite there yet with what are the interventions. And there's some really people, particularly from in the educational space, who we're working with to sort of think about what are those interventions, what do they look like? How do we help foster those skills? I think you're absolutely right, because it's an opportunity, right? Because you're just in the clinic once every so often, but if we can sort of teach you something to do at home, right, then that's the whole
I think it's really interesting. The majority of our comments from people here have been adults who are saying that they were born prematurely.
Wow.
So this Juliet, she
Yeah.
is an adult preemie. Let's see. She was followed till she was 5.5. Between 1980 and 1985. She said her follow-up was quite poor, and it was done in the Netherlands. And so she's saying that looking back, she had more issues with fine motor skills, such as handwriting, and lung issues quite often. She didn't receive proper help or support in school. And then, of course, she makes the comment here about having to advocate as an adult now in the system. I just think it's very interesting that the audience here today, and we've got some beautiful connections happening. You should take a look of people kind of networking, but it's showing that we have a whole population of people who are feeling this gap.
Yes.
Whereas now, I mean, what we're doing for babies at this point in time is tremendous, but that there's this gap of adults trying to self-advocate in the system.
Yes, exactly. This is really, really striking, and I'm so grateful for this community here for speaking up and talking about it, because I think that is not. It's not common that we talk about follow through, and as I said, follow up being time limited, right? It's for 2 or 3 years, and then you sort of say, okay, great, you've caught up, quote unquote.
Right.
But of course, we know that not to really be the case, and that the lifelong medical and perhaps developmental challenges, right, will linger. It doesn't mean that you're not, succeeding and thriving, but there are still things that are, relevant.
Right.
And I'm really curious. I mean, this is why we need to engage with adults who are preemie to know about these issues, to know what it is that would be helpful, right? Because I'm not even sure what that would look like. Oh no.
Sorry about that.
Okay.
Popped off there for a second, but we are going to have to wrap up.
Oh, not sure if it's.
Sorry, I think I'm back now.
Yes.
Okay.
Yes.
We've got some great comments. A lot of people saying thank you for the excellent presentation. So I hope you get a chance to look at that. But one, to thank you for joining us today. We'll say goodbye, and I hope we're able to talk again, because this is a very interesting topic, and like I said, lots of people engaged. So I think it's a lot of people are interested in it.
Anytime. It was such a pleasure. Thank you so much, Leah.
Thank you. And thank you, everyone, for joining us here today for this episode of Preemie Chats. This was sponsored by AstraZeneca, and they give ongoing support for the educational program. And so a special thank you to them. Just a reminder that if you missed part of today's session, you can head over to CanadianPreemies.org. You can watch the whole thing there and see all past editions of Preemie Chats. You'll also find many resources and support options available, and you'll be reminded that CPBF is a charitable organization, and it depends on support to continue its important work. And so we'd ask that you consider that when you're giving gifts. That is a special way that you can help support families and support CPBF's mission to empower families of premature babies in and after NICU, every step of their journey. Together, we create a brighter future for all preemies and their families. I hope you're able to join us here next Friday at 1 p.m. Eastern Time. It's going to be micro preemies born with BPD. You won't want to miss that, and I hope that you all have a great week.